Good morning. Good morning, everyone, or I guess good afternoon or good evening, depending on which time zone you're in. So I'm very happy to introduce our next session. It's called Immune Responses to Focused Ultrasound and Ways to Monitor This. Our panel today, in alphabetical order, is first is Dr. Arvanitis. He's an assistant professor at Georgia Institute of Technology. He's an assistant professor in the Woodruff School of Mechanical Engineering and the Coulter Department of Biomedical Engineering. He earned his degree at the University of College in London, and his research is particularly focused on biomedical acoustics, focused on therapeutic and image-guided therapy. Dr. Bullock is our next panelist. He is an associate professor at UVA School of Medicine. He's a tumor immunologist and focuses on how TNF superfamily members can be leveraged to promote anti-tumor immunity. He's worked closely with folks in the brain tumor realm, particularly with Dr. Price, to kind of develop and enhance the microbubble technology that we were talking about in the prior session to help immunotherapy. Our next panelist is Dr. LaVallee. She's the Vice President of Translational Medicine and Regulatory Affairs at the Parker Institute. She obtained her PhD degree from UCLA and has been a big part of helping us get drugs from development or discovery into late-stage trials. And our final speaker is Dr. Sun, who's a postdoc at Brigham and Women's Hospital. He's in the Department of Engineering and Radiology. And he also has done a lot of work under the guidance of Dr. McDonald and Mitragotri for, again, combining microbubble technology with immunotherapy. Now, the title of the session is really Immune Response to Focused Ultrasound and Ways to Monitor This. But, I think the majority of our expertise today is really kind of in that, in the preclinical realm and getting technology and new ways to do immunotherapy. So we'll focus on that. And then, I think we'll also pick their brains to get thoughts on how to do immune monitoring. So, I was thinking maybe Dr. Arvanitis, you could just present maybe a little bit of, or we could start with Dr. Arvanitis, and you could start with, just maybe some big picture ideas on how you see focused ultrasound and immunotherapy coming together, and maybe comment on immune responses.
Yeah, thank you. Thank you very much for being here, for the invitation, and thank you very much for the nice introduction. So, I guess, one of the big questions or like important questions that people ask, whether they are in the field or they are newcomers in the field, is whether focused ultrasound can produce immune responses. So, and I think that's something that, is quite important, is an important question, because you can see the question is the notion behind that is, can we use ultrasound alone as a method to mediate immune responses? And or we need some drugs. So with respect to using ultrasound alone, I would like to focus here because there's another session after that. So there are like several things we can learn from that question. We can learn a lot of things for things that happen in healthy brains. There is a lot of work that is going on, and there have been reported several responses that indicate that there were some inflammatory signatures in the brain following focused ultrasound. There is also several studies that we've done, mostly supported by the Focused Ultrasound Foundation, where we tested different modalities, modalities meaning thermal or mechanical effects and different permutations of those two. And we looked into brain tumors, and we tried to see, specifically we used the GL261 glioblastoma model, and we tried to see whether we can change the immune phenotype of the tumor microenvironment. And there were like several different flavors, but all the studies to some extent pointed to the direction that there are some significant changes in the immune environment. So this study came with a caveat of using a tumor model with low mutational burden and a tumor model that may be weakly immunogenic. However, there is evidence there that focused ultrasound can produce responses. I guess the big question that comes now is, are these responses durable? Do these responses lead to some meaningful changes with respect to therapeutic outcomes when we come to treat brain tumors? And I would leave there, so I want the other panelists to contribute, but I think that those are the two questions that are quite pressing, and we need to find the ways how to address them in a more conclusive way.
Great, thank you. So yeah, I think you brought up three great points. We need to also make sure that we mention that Dr. Trimby had a really great talk in the pre-education session, and she did touch upon the differences between the mechanical and thermal. So we want to definitely touch upon that today. Second point that you brought up are the models, and you kind of implied that there are different types of tumors that are going to respond, and mutational burden was one of them. And then third is the monitoring. Dr. Bullock, we'll turn to you for.
Thanks, Michael, and the Foundation for inviting us here. Costas raised some great points, but I think I'm going to approach it from the biological perspective, the immunological perspective in particular. Our understanding of the relationship between the brain environment, and particularly the tumor brain, the glioblastoma environment, and the traditional sites where immune responses are initiated, i.e. the lymph nodes, is undergoing tremendous evolution at the moment. And so we're beginning to understand that the traditional lymphatic drainages that would be responsible for promoting immune responses can often be compromised. In the space of glioblastoma, the meninges are a site which we want to be considering as a potential site of T-cell activation. And whether there are cellular components within the tumor, particularly the glioblastoma tumor microenvironment, that may contribute to the initiation or the sustenance of any focused ultrasound mediated immune response. So I think that context needs to be considered when we're thinking about different focused ultrasound techniques. For example, when we're taking ablation techniques, thermal or mechanical, if there's lymphatic drainage is compromised, then one has to consider whether that's going to allow the elaboration of the type of immune response which we think would be able to curtail the tumor's growth. So we need to be thinking, is the type of damage, of the type of ultrasound modulation of the vasculature. We've heard a lot about the microbubbles approach of just opening up the blood-brain barrier to permit the tumor microenvironment to become more permissive to immune response. All of these need to be taken under the context of our evolving understanding of the actual immunology of the tumor microenvironment in the brain. And I think we've learned primarily our focus has been on using microbubbles as a mechanism of disrupting the blood-brain barrier, the blood-tumor barrier. And as Costas indicated, we certainly see evidence of mass or, if you want, proto-immune modulation by doing subtle damage, but not extensive immune modulation to the extent that we may have seen with a thermal ablation in a subcutaneous tumor. And so I think this all needs to be considered. The immunology, the immune structures, the immunosuppressive nature of the tumor, and how can we leverage aspects of focused ultrasound to intervene with each one of these stages, the initiation, the promotion, and the acceleration of the immune response, I think is all going to come into play. And there may be different flavors for different conditions. Cancer is not one disease. Glioblastoma is not one disease, and that heterogeneity is going to come into play as we think about what's the best type of focused ultrasound modality to deploy.
Great, thank you. Yeah, I think we appreciate those points too. I mean, the heterogeneity of GBM, some even argue that when you're doing these trials, it's really they call it a basket trial because it's the heterogeneity is so great. It's almost like two different tumors.
I call them basket case trials.
And the lymph node, I think, is a very important point that we'll come back and touch upon too. I think that Dr. Trimby had a really nice slide showing this. I think it's from Dr. Melman's article, showing where tumor immunology and points to leverage for tumor immunotherapy could be at points where we could try to take advantage of in generating an immune response. But the lymph node is a key part, and that's I think people have come to appreciate. And then, of course, the microenvironment is something that we need to overcome, and the uniques and the nuances, which we'll discuss. So, thank you. And Dr. LaVallee,
yeah, no, I'd also like to thank the organizers and Dr. Lim for including me in this discussion. And I think we've already covered enough topics to cover a day's worth of discussion. But I think, you know, as we've been thinking about it, one, to add to the complexity, I guess, of topics to cover is one, defining immunotherapy. And broadly, a lot of people think of checkpoint inhibitors, but we also have a large focus on bringing cell and gene therapy into the brain cancer treatment paradigm. And so the question is that I think being involved early days with immunotherapy, I can remember discussions, even could we combine it with chemotherapy? Because does that make sense? Would we modulate the T cells that they wouldn't be able to get activated? And we've seen that to be an incredibly successful combination with checkpoint inhibitors. And so do we fully understand the why? Is it immunogenic cell death? How it fits in that cancer immune cycle that was published, that was just referenced by Dr. Lim. And so I think really doing the thoughtful science of understanding the interplay between the focused ultrasound, the different modalities, as been described by my other panelists here, and how that modulates the immune system, because it's both the complexity of what it's potentiating, as well as what's the sequence to add. We have seen in studies with PD-1 inhibitors, with GBM, I think a surprise, at least to me, that there was a big difference between the timing around neoadjuvant and adjuvant treatment with PD-1 and its outcomes for survival. And so really appreciating and doing those deep translational endpoints as we're setting up the studies, both in the mice and in the clinic, to use the data to really guide us as to what are the mechanisms that are being potentiated. Is it the dendritic cell presentation? Is it increasing T cell infiltrate into the tumors? Is it modulating the TME from the different immunosuppressive environment? And how then can we best combine it with the various therapies that are available?
Yeah, no, I agree with you. I mean, I think it's interesting with focused ultrasound that it's like stereotactic radiosurgery, right? It could be a definitive therapy in itself, but it could be a therapy to start kindling, as you suggested. And you know, in terms of sequencing and where, because ultimately immunotherapy, you're right, is going to be a modality, right? It's an arm to treat cancer. It's not going to be the magic key to curing everything. So the how to sequence and how to put it in relation to other known cancer therapies is definitely a big question that we need to sort out. I agree with you on that. Okay. And Dr. Sun, so would you like to also comment?
Yeah, sure. Thank you, Dr. Lim and the Focused Foundation. It has been, to echo everybody here, I think intuitively, the immediate thought of the focused ultrasound application for immunotherapy is to deliver more immunotherapeutics and antigen release. So the question or concern would be, we know that the recent GBM trials of the checkpoint blockades are mostly failed. So biggest concern is, if we can deliver more drugs, can we make a big difference? So what I want to add on to that is, other than the drug delivery, whether we should think about more of the trafficking or activation of the immune cells. Maybe that's what focused ultrasound can play a bigger role in this whole combination therapy. And especially for GBM microenvironment, it really has a very low number of T cells, especially CD8 T cells. And there's a big issue of this T cell infiltration. Also, what I want to point out is the myeloid cells. This is something that, again, might be biased of that because what I'm doing now, but macrophages and microglia might also play a big role. This is something that maybe checkpoint blockades like PD-1 blocking won't really help a lot on that. That's something maybe the focused ultrasound can take a place there, especially when we see a lot of preclinical and clinical evidence from Alzheimer patients on the microglia activation. This is something I think that would be interesting.
Great. Well, thank you for that. I think, again, you're highlighting the importance of the microenvironment. And, the myeloid cells are a very important part of glioblastomas. And in fact, as we talked about these cold and hot tumors, when you look at something like pancreatic cancer and glioblastoma, these are both, myeloid-rich tumors. And I think everybody's been kind of hinting at that. So, in terms of focused ultrasound, maybe we'll focus first on the microenvironment. What are some thoughts on, how focused ultrasound could potentially modulate the microenvironment and maybe even the myeloid cells? Maybe we can start with that.
All right. Do you want people to jump in?
Sure. And I think it'll be also nice to highlight, at least I think there's an importance with highlighting myeloid cells and in the lymph nodes too. So it'll be great.
Yeah. So any opportunity you have to deliver an agent that we think can modulate the tumor microenvironment so that it could be more inflammatory, there's two sides to that sword, right? There's one that you're going to potentially promote an immune response that has capabilities of attenuating the tumor, but there's going to be some potential consequences to the patient, which we have to be very cognizant of in terms of unwanted sequelae. But if we're just taking it at the point of dealing with the myeloid cells, there are well-established approaches that are known to polarize myeloid cells in a way that will allow them to produce the cytokines that we know will support T cells, will have direct activity against tumors. So we could be considering toll-like receptor agonists, we could be considering STIG agonists, antibodies that have the potential to activate myeloid cells. CD40 is the sort of classic paradigm that we think about in this space. But then there are also sort of antibodies that are associated with depleting different subsets of myeloid cells, which are considered antagonistic to immune responses. So making sure that we can improve access at using doses of antibodies or modulating agents that are decreased as a function of being able to open the blood-brain barrier, I think of a huge opportunity, a huge space to work in, and may deal with both sides of the sword, what I'm talking about, both promoting the immune response, but also de-risking the patient.
That's a great point. I think if you think about like nature, and nature always has a purpose for things. And so you highlighted the fact that there are a lot of different myeloid modulators, right? And so I think it highlights the function that the fact that these myeloid cells have lots of different function and are central to many different processes. And I think maybe it'd be nice, maybe you or Dr. San could comment on what cells are you referring to when you first talk about myeloid cells? Because it's one of those things where I think people love to say myeloid cells, but I think it's important for the audience to appreciate what they are, or at least what most people are referring to.
So I'll let Tal chime in I'll come back to dendritic cells. Tal, you go ahead with your preferences.
Thank you, Dr. Bullock. I'm thinking about, I think that intuitively people are thinking about microglia. This is something that's always inside the brain, also in GBM. It's about, I think it's 20%-ish, the resting microglia. And what's important about that, it's that I do see several papers, not really in focused ultrasound, about other technologies that either radiation or kind of laser ablation that could activate a microglia, which means that they can sort of activate it, and then they change the morphology. Also, this could be, I think it's less defined at this stage, because even if they got activated, they could do good or bad. By that, I mean, it could maybe eat your antibodies. It could just destroy your immunotherapeutics. So microglia is something I think is very important. Also, monocyte or macrophages, this is something people always talk about. This is something could be interesting because we are talking about focused ultrasound, especially when we add the circulating microbubbles. It's actually mediated from the vasculature. That's how I think the monocyte can get into the brain. And yeah, so mostly these two cells.
Yeah, that's a great point. I mean, microglia certainly are a big part. Some people believe that the microglia are locked, whereas the macrophages that come in, I mean, there's the other favorite term that a lot of people like to use are MDSCs, myeloid-derived suppressor cells. And a lot of them do seem to have a bone marrow origin for that. And if it is, they're more on the lineage of the macrophages, but very complex topics. Agreed. We have a question from the audience. Immune modulation is a dynamic process. At what time point do you think are optimal tissue? So I assume they're saying, at what time point do you think you want to try to intervene with, probably in context of focused ultrasound? Dr. Arvanitis, do you want to comment? You've done a lot, it seems like. Or?
Sure, I think, yeah, that's a really, really important question, right? So it's definitely the tumor microenvironment and the impact that focused ultrasound has in the tumor microenvironment is a critical component here. And I think this is what we're talking about, how to use a potentially focal therapy for a treatment that is like mostly systemic. So how we can modulate, how you can change the properties, or how can make the tumor microenvironment more amenable or more sensitive to immune cells, and or whether we want to deliver drugs to the tumor microenvironment where we can make it more, sensitive to that, as now suggested. So evidence, in brain tumor microenvironment has been limited to two different time points, I would say. One is, we apply the ultrasound and we sacrifice the animal maybe 6 to 24 hours later. Again, there are many studies out there. That's the most studies that have been reported. And those are mostly studies in healthy brain. We have seen like significant, expression and upregulation of different proteins that might mediate immune cell trafficking or might facilitate improvement of penetration of antibodies or other drugs. So that's a time point that I think defines to some extent that when to do things. But I would also like to point like a very, I think, intriguing study, a very, very interesting study that have happened by, I think it was, I don't know if Tim was involved in that, but, Richard Price as well, where they apply ultrasound before the administration of antibodies, and they did see a huge effect. So this speaks volumes to modulating the immune tumor microenvironment in terms of like making it more sensitive, more able to absorb drugs. So then the time point is like, I think there are several studies that have drug delivery studies that have done survival and not immunotherapeutic studies, but they use immune competent mice. And in that respect, you can see the control data. We are looking at the control data right now, and the control data is like tumor only, no drug, no intervention, and focused ultrasound only. And we did see that, in fact, we didn't see any changes in the survival. So we don't see any direct effect in terms of like how ultrasound, mostly in blood-brain barrier, can change the infiltration or the effectiveness of cells. So these two data points, they're like quite sparse, I would say. More detailed analysis needs to be taken place, and also in the tumor microenvironment. But this current evidence favors administration protocols around the time point that focused ultrasound happens. Whether it's going to be a day before or a day after, it's not clear, but that's kind of like, the time point that seems to be more meaningful as far as changes in the tumor microenvironment are concerned.
Dr. LaVallee, kind of on this question, right? The tumors are dynamic processes Dr. Arvanitis is talking about and kind of hinted towards. With some of these conventional therapies, obviously that puts pressure on the tumors, not just from growth and kinetics, but probably immunologic pressures too, whether it's chemotherapy, radiation. And so what are your thoughts on how focused ultrasound could, obviously there's very little data now, but do you have thoughts on where the optimal timing for something like focused ultrasound could fit in?
I don't know that I have the thoughts for the timing per se, but I think from the experimental design, I think the complexities of the system have to be appreciated and have all been mentioned here. So like you said, there's an immune system is a complicated milieu of cells. And so really characterizing that and the heterogeneity. I mean, so one of the studies that we're doing at Pisces before we design a clinical study is to collect a large number of brain tumor samples. And we've set up a high dimensional imaging panel specific to myeloid cells to try to really characterize what's the heterogeneity and not only who's present, but is there differences in the regional spatial areas. And then understanding the disease, you can then look at the modulation. So thinking about the timing from your clinical hypothesis, if it's really to disrupt the tumor and open up the barrier, setting that up so that it would be delivered early in treatment, and then look at layering on your immune agent, whether it be trying to get a cell therapy into the brain with better T-cell infiltration, or is it modulation of the dendritic cells and things? And I think really being very mindful of the assumptions that are being made and the questions, because if there's one thing I've learned early in my career from the translational space is you usually are wrong, that just let the data tell you. But if you ask the question and you show that what you were thinking in the human with all the complex diseases different than the mouse studies or the preclinical, then maybe it can inform you better how to go. And many people look at that when the clinical data comes out to be very different, to be a failure. But in fact, often we learn more. And I think we have seen many times in drug development where people have appreciated their being wrong and adjusting to be data-driven. So I think the number of questions are large, but having a clinical hypothesis and then setting up the experiment in humans or in mice to really ask the question is how correct you are, and having as much information to support it, I think is the only way to inform us. I think in terms of the sequencing and the dose of many of the drugs, we are at a loss for exactly what they are. But the more data that we can generate early to inform us and using the clinical endpoints to guide us, I think the better off we'll be.
I think you bring up a great point, right? Which is the models, right? We always go back to mice, and we're real good at curing mice, but can you comment on the concept? I don't want to call it new, but I think it's very exciting and revived on the phase zeros or the window of opportunity trials, because this seems to kind of dovetail in what you're saying. You give your drug therapy and then take the patients to surgery, you can actually have an idea of what's going on and still follow the patients clinically.
Yeah, no, and I think the window of opportunity studies are a really nice way to set things up to get the more information as you go on to to understand the development.
Yeah, great. We have another question from the audience. People wanted to follow up on the topic of lymphatics that Dr. Bullock mentioned. Thoughts on CNS lymphatics, and draining lymph nodes to cervical neck and direction of focused ultrasound delivery to either target large meningeal lymphatics or avoid it?
Yeah, so our understanding, so there's some recent studies, high impact studies, and they were in mouse, but there's some human correlations that came along with it, indicating that in many instances of GBM, that the traditional lymphatic drainage that was recently discovered lymphatic drainage that the Kipnis group identified is compromised for some reason in the context of GBM. And so that raises the question of how would an ablation approach be influential in releasing antigen, allowing dendritic cells to traffic to the traditional sites of priming if the lymphatics are compromised? So you're faced with two choices there. The one we're taking is, can we move the lymph node to the tumor, i.e. bring dendritic cells into the tumor and use capacities of focused ultrasound to bypass lesions in the lymphatics? And the alternative approach is, how do you use elements of focused ultrasound to deliver agents that may be restorative to the lymphatics? So the agent du jour is VEGF-C, is supposed to be able to advance lymphatic development or recuperate it. But this is just sort of a nascent concept at this moment. It's a new compound, it's a new therapeutic in the brain space. It could have all sorts of untold consequences, but it needs to be explored. And I mean, it raises a really interesting aspect of ultrasound, partly revealed by some of Rich Price's studies, that as you open the blood-brain barrier and you allow flux of materials into the tumor microenvironment, and he studied antibodies, but other agents, how do they then interact with the draining lymphatics post opening the blood-brain barrier? And it's going to be a really interesting area to explore in terms of, can we use the opening of the blood-brain barrier ultimately to target the lymphatics and then the draining lymph nodes? And so you sort of complete the circuit, the cancer immunity cycle, by using focused ultrasound in that manner.
And could kind of follow up on that, one of the questions really is, what if you were to take the focused ultrasound and target the meningeal drainage sites? Do you think that would augment, or do you think that would detract an immune, first probably immune antigen presentation really, but ultimately immunotherapy?
I should defer to someone else on that.
I mean, I tend to kind of like step back in questions in this direction in a way that I take the engineering or approach, which is what is we want to accomplish here. I mean, pointing the ultrasound will produce thermal or mechanical effects. We know that we can tune all those, and we do have to monitor both the thermal and mechanical effects if we want to do mechanistic investigations. So, and also what we do know is that ultrasound, and focused ultrasound as it tends to be called, produces three different windows of opportunity. These are like temporal windows. In a sense, as we've seen in the blood-brain barrier, it lasts for a finite amount of time. Because it is focused, it produces spatial windows, so we can go in localized fashion and change some properties. And also it produces molecular windows, in a sense that we've seen that we can change the protein expression for a finite amount of time. So I think if any of those interventions are meaningful from biological and immunological standpoint, and or are needed to be directed towards the lymphatic system or other components of the human body that is related to the immune system, that's possible. But we still have to really ground down to what are the things that we are trying to improve. What is the goal that ultrasound can then, as a physical technology, as a physical method to interact with the tissue, will be able to essentially tip the balance of a given variable, of a given substance, or of a given antigen or drug.
I mean, I think that's a really important point, that you can modulate different tissues. And so, I think the bottom line is nobody really knows what will happen when you focus ultrasound on the meningeal. You know, I don't know, you don't know, but maybe you could, it sounds like based on your technology, I mean, based on your assessment from physics, you could potentially facilitate passage and trafficking of cells with it. And so hopes would be to, you know, have that. I think it's an important question to ask and do that.
Yeah, I mean, it's a fantastic question. And I think it's I would like to maybe refine a bit the questions if I can, in a way that what are the bottlenecks that we're trying to overcome? And that will maybe use the ultrasound to overcome the specific bottlenecks. And that's I think that's kind of like, is really, that's the beauty of these 2 days, I think, bringing together scientists, clinicians, people that have background in quantitative, also qualitative and unique insights to identify bottlenecks potentially that maybe physical methods like ultrasound could potentially overcome them.
Great. I guess we have time for one quick question, and then maybe, so there's a question of microglial activation with LIT, which is the laser. Have any of you studied the microglia with LIT or have thoughts on how laser interstitial therapy could either make the microglia pro or against an immune response?
I thought we were talking about focused ultrasound.
Yeah, I think in Dr. Trimby's comment, there's a thermal aspect to focused ultrasound and talking about how that wasn't as effective in generating immune response, maybe to piggyback on that question.
I think there's an important concept that's driven out by the juxtaposition of LIT. So it's the type of damage that's been introduced to the tumor, right? So qualitatively and quantitatively, I mean, quantitatively can be regulated by the amount of tissue treated, but qualitatively, what are the what we call damage-associated molecular patterns released as the tumor dies, and are they similar between these different modalities? So the mechanical ultrasound, thermally ablated ultrasound, LIT, do they cause the release of different intensities of components that we know will promote the activation of microglia, of dendritic cells, or other myeloid cells in the tumor microenvironment? And at this point, I think it's a complete black box. We don't know the answer to that, and it's a particularly exciting area. We're doing some studies comparing stereotactic radiation with ultrasound, focused ultrasound, to understand the commonality and differences between those, which ultimately will inform what type of adjunct therapy we want to introduce with the focused ultrasound. That's my 2 cents on it.
I think that's a great point. I mean, it goes back to the whole point that there's a lot of myeloid modulators, and they'll probably fall under what they call DAMPs, what you mentioned, damage-associated molecular patterns, and those are effective, and those will do very different things than maybe a viral protein. But thank you very much for answering that. So with that, I think we're going to wrap up. Dr. Arvanitis, Dr. Bullock, Dr. LaVallee, and Dr. Sun, thank you again for your time and thoughts for this session.
Thank you.
Thank you.